did my project on use of an integrated approach to treat complex trauma in patients with a history of cancer. Really, the summary of this project is looking at the fact that no standard intervention does exist to treat complex trauma. Although there are trauma interventions to treat PTSD, they largely don't address all of the symptom clusters associated with complex trauma. So as you can see in the infographic here, PTSD and complex trauma do share 3 primary symptom clusters, but complex trauma has the additional affect dysregulation, negative self-concept, and the interpersonal disturbances. So for this piece, in addition to those things, patients with the condition may also be at increased risk for developing disorders related to immune dysfunction, such as cancer. So these are the primary problems that the current project sought to address. So I did this primarily using the evidence-based intervention of eye movement desensitization and reprocessing. So this was the primary trauma treatment. And then 2 interventions were also integrated into the standard protocol to really attend to those untreated complex trauma features. So these adaptations were integrating schema therapy and internal family systems. This was implemented at Roswell Park Cancer Institute, and the who needs to change here. So this included the clinician implementing the intervention, so that'd be me, the clients receiving the intervention, and then the referring departments. I laid out kind of that form we used to kind of identify the barriers and facilitators. So for me, I needed to make a practice change, so I needed to implement that integrated intervention. And the primary barrier to this was simply the complexity of the intervention. EMDR is a complex intervention, and then add 2 others to that, and it gets even more complex. Facilitator was that I am certified in EMDR, and I have training in the other 2 interventions. For clients, they needed to receive the integrated intervention, and primary barriers to that were around simply lack of knowledge about what would happen if they completed the treatment, if they didn't complete the treatment for consequences related to their complex trauma. Individuals with complex trauma also tend to have that limited emotional regulation. So that was another identified barrier for them. For the referring departments, they needed to refer patients for their study. And the primary barrier there was they were simply unsure of how the intervention could help. But they were very willing to learn, and they seemed really engaged with the project. The intervention itself may be effective in addressing complex trauma symptoms in patients with a history of cancer. And like I said about the schemas, targeting those memories may have an impact on each schema outcome. For the population in general, I did see something really interesting was that 3 schemas, that's the unrelenting standard, self-sacrifice, and the mistrust abuse. They appear to be highest in this population, and although each significantly reduced through treatment, they were each still the highest after treatment. So there may be a potential link between these schemas and cancer occurrence. Ideally, I'd love to conduct some interdisciplinary longitudinal studies to see if there is a relationship between complex trauma and the development of cancer, or even those schemas in certain cancers. I am working on trying to publish my current findings to generate some support and see if I can conduct additional studies as well.